Hi, Rima. Well,
I
very good evening to all of the and the previous one. We are on third series of the grand rounds and 34th series of webinars overall. And we are truly honored to have all of you joining month after month for the past 33 months. It's really a huge honor for us, and you guys are like family. So this time the topic that has been chosen by education team being led by John, Alejandra, Rima are here, who are working extremely hard on these grand rounds. And I'm very happy to announce that they are compiling it in the form of a book, which hopefully shall be available to you once this year is over.
It sounds like Vishali's connection is having some challenges. So I'm John Kempen, and I guess, sort of organized this session on behalf of Alejandra and Rima and the IUSG. And so welcome, everyone. We're extremely honored to have an extremely distinguished panel of experts with us. The format of this is to first begin with a thematic lecture, in this case talking about posterior uveitis, and then three cases that we selected, sort of choosing somewhat unusual ones so as to avoid future sessions that'll be focused on a particular kind of posterior uveitis. So we're beginning with the thematic lecture by Professor Carlos Pavesio, and we're extremely honored to have him. He's professor and director of the uveitis service at Moorfields Eye Hospital, and an extremely well-known uveitis specialist from whom we can all learn a great deal. And thank you so much, Carlos, for joining us at an inconvenient time and taking on this opportunity to teach us. Thank you very much.
Thank you, John, for the invitation, for your kind words. Thanks for the USG for inviting me and for organizing the session. I will share my screen with you now, and I hope it's going to work. Let's see if you can see me now. Let me know if it's working, just to make sure it's working. Okay, it's on. Okay, great.
It's on.
Very well. So the title of the presentation is pretty much talking about pearls, and I'll try to give you some overall aspects of the strategy behind the diagnosing and management, and I will put in some pearls in there, which is what I hope will be adding a little bit extra to this presentation. Just to show you my disclosures here before we start. So when we are looking at our uveitis patients, one consideration is really we want to make the diagnosis, and we need to take the whole picture as a whole. We don't want to look at just an eye. We have more around that eye that needs to be taken into account. So many aspects of the patient in terms of social history are very important. But the one thing I always stress to you is really important to understand the signs and symptoms, find the signs and understand the symptoms at a very early presentation, because these are the manifestations before the disease is modified by any intervention. So many times the patient come to you already on treatment that modifies the behavior, and you want to understand what was happening at the very beginning, because that's very valuable information. And of course, without a full ocular examination, you'll not be able to reach your conclusion. So the one point about this history, I think in ophthalmology, sometimes you underestimate the value of history. So the history and your clinical examination will guide you into what investigations you end up choosing. So complete your examination again, and then look at the systemic aspect of the patient. So why do we normally investigate? I think we investigate mainly because we want to make sure we are not missing an infectious disease, or because there might be a masquerade. In our case, of course, lymphoma comes at the top of our list, but there are other forms of masquerades that need to be also excluded. This is something that is not new. We look at this paper 1995 from our friend Khalid Tabara. He already spoke about the issue of excluding infections as the main objective of the investigation that he would consider for laboratory investigations in posterior uveitis. So why is that important? Because if you give antibiotics to an infectious process, you delay the adequate treatment. If you give immunosuppression to an infectious disease, you end up with a catastrophic outcome, and you may be missing a malignancy in the case of a masquerade. So the main objective is diagnosing, especially the differentiating infections from an infectious uveitis, establishing the primary location of the process, which we'll talk about a bit later on, and then how severe, and if possible, establish a syndromic diagnosis for that uveitis, even though etiologically may not always be possible. And then they evaluate the possible strategies for management, taking into account the general health of the patient and other concomitant therapies. This is maybe a bit contentious. Some of you may disagree, but if a simple anterior uveitis, the first episode is someone who doesn't have any medical history, mild, unilateral, non-granulomatous, you may get away without investigating. Some people may argue, "I'll do an HLA-B27," but the likelihood of finding an underlying disease of significance is very, very small. So these patients might be treated as a one-off and not investigated. But other reasons why you wouldn't investigate is if you have a known diagnosis. So someone who has a traumatic picture, you know that the reason for that process is likely related to trauma, as it is in the case of the iris atrophy, changes in pupillary shape that you know it's herpetic in origin. As someone with a trauma in one eye and developing inflammation in the other eye, it's going to be a sympathetic ophthalmia clinically. A recurrent retinitis adjacent to a previous scar is going to be toxoplasmic retinitis. And if you find a worm that is migrating the back of the eye and generating all this crop of yellowish lesions, you know that's Duzen. So the point is, you don't want to be wasting time investigating something that is clinically obvious. But then if you have to investigate, how do you do that? So again, we talked about history and clinical examination helping you choose what you're going to do. So essentially, again, what we said before, examination of the patient, look at this, especially the history of the ocular history of what happened right at the beginning, what interventions were used, how they responded or not responded, and if the patient has these other general histories that are very important. I'm not going to spend too much time here, but you all know the value of this information. This is something that Doug Jabs published some years ago now, many years ago now, but it's important to characterize the dimensions of the uveitis. So is the course of the disease, the laterality of the disease, where is it located predominantly, anterior, intermediate, posterior, pan, the location in terms of retinal, choroidal, is it a multifocal, unifocal, and then if it's connected to an infectious process. Clearly, looking at the host in terms of being a child or an adult, and looking at any other underlying systemic disease. So this is the kind of considered outdated approach. So you can remember patients filling these huge questionnaires. Some of the questions we didn't know ourselves what it meant, but we created these questionnaires pages long, and they were not very helpful, but that's how the approach was at the time. Then you try to identify symptoms of a systemic disease and then go for laboratory evaluation. All this was based on a flawed notion that a uveitis typically is a manifestation of something else, and that something else has to be identified regardless of the cost. The other aspect, the flawed concept, is that discovering an idiopathic systemic disease will make the uveitis no longer a non-idiopathic. So these are the things that have changed. So how do we go about this now? You have the history, examination, imaging, which is very helpful, supportive of the diagnosis. You classify, find a classification of the pattern of uveitis, take into account everything else we discussed before, and you try to reach a phenotype. And with that phenotype, you will then create your list of differential diagnoses. You will select the investigations, which will then allow you to exclude conditions which are going to be serious from the point of view of complications, infectious, or malignancy, and then you propose your treatment. So make a specific diagnosis of a specific uveitic disease. That's what we try and like to achieve. So it's important that you look at your patient examination and everything about the patient and look for patterns. So different things can help you in reaching your diagnosis. So starting here, uveitis and scars. So you look at the back of the eye, the presence of some lesions, especially if they're associated with like toxoplasmosis and adjacent lesion, the presence of a scar will help you. The Dallenfuchs nodules that you see, especially in inferior retina, in VKH or sarcoidosis, and then look at eyes that have scars but are quiet eyes. Then we give you some clues. Which vessels are involved? So is this predominantly arteries, predominantly veins? Keeping in mind that some conditions will involve either of those. Skin lesions, so we know very well that many diseases, the skin lesions will give us a clue of what is the diagnosis of the eye condition, as you can see in these images here. But I want to add something else that's been coming, we saw more recently. So it's when patients present with kind of inflammation in the eye, we can see here this individual with this choroidal lesions and macular edema, and this patient had features that were suggestive of a sarcoidosis, and you see the fundus image also showing the snowballs. Well, the uveitis was triggered in this case by a tattoo. So the pigment of the tattoo was regenerating the reaction. You can see here, it's important when you look at the skin, because potentially this could be a good clue for you that if the patient is having a reaction at one of the sites of the tattoo, this could be connected to what's happening in the eye. Drug-induced uveitis is really, really important to get. It's not common, but if you get the history of the drugs that might be used, you may end up finding there is a connection between that drug and what's happening in the eye. So systemic treatments, cidofovir, Janet, who's going to be discussing later on, looked into that in the past. We were treating patients with that for our CMV retinitis. It's a drug that could potentially be very serious complications to the eye, especially hypotony. But it's important to remember that these drugs, such as rifabutin, bisphosphonates, which are very frequently used in our patients with osteopenia or osteoporosis, the anti-TNF treatments we're using more and more for the management of non-infectious uveitis, and more recently, the immune checkpoint inhibitors, especially treatment of melanomas, are associated with the images you see on your right, exactly a case related to one of those drugs. Intraocular medications, we were familiar with the use of tretinoin acetonides to treat inflammation, but we were also aware of the non-infectious inflammation generated by these injections. We're the same with the anti-VEGF therapy we're using today. Many of those drugs can induce inflammation, and we should avoid injecting eyes which are inflamed. Rozisomab was the very important message of how serious some of these complications can be. And some topical medications can also produce uveitis. Don't forget vaccines, especially recently being all aware of the COVID situation. And we all know that patients reported, and we've seen them with inflammation in their eyes. Hepatitis B seems to be the most common one, but all these other vaccines I'm mentioning here can be linked to inflammation, but we need to outweigh the benefits outweigh the risks. So we don't recommend patients should not take a vaccine because of an potential eye problem, because the frequency is low and most of the cases are not serious, even though potential serious problems can occur. But we should not advise against vaccination. So this is a way of finding an association between the use of a drug and the uveitis, and this Naranjo criteria will help you define if that association is definite, is probable, possible, or doubtful. So these are 13 points there, and you can use that to try to establish how likely it is that the association exists. So the wrong way to investigate is if you just try to request tests in an attempt to find a reason for that problem. So if you look at this table here, if you don't have a clue, you're hoping to tick all the boxes and find out an answer. Most of the times you'll get it wrong because the result will not match what you're seeing, and you end up with the wrong conclusion and consequently the wrong approach. So is this a good thing to do? No, definitely not. We should not be doing that. You should be selecting tests according to everything we discussed before. So when do you stop testing? Well, if your diagnosis is established and you're happy that the clinical picture is behaving adequately, you stop investigating further. And once the indicated tests have been completed, so you don't need to be coming further and further because you already reached your conclusion. So you can then reach a point in when you're satisfied in you establishing your treatment strategy. Two things to mention separately here. Syphilis, even though not a very common cause of uveitis, the numbers, of course, of syphilis cases are increasing progressively, but syphilis can result in so many different phenotypes that it's impossible to ascertain that someone doesn't have syphilis until you test them. So use a specific test to identify the exposure, and the non-specific tests are helpful for disease activity. Remember that early intervention with antibiotics and steroids, which are used for two reasons: Preventing paradoxical response and limit tissue damage is important for the favorable prognosis in these cases. Tuberculosis uveitis, be aware of the origin of the patient. They may come from endemic areas. Remember, the chest x-rays are not very helpful. CT scans of the chest are much more sensitive in diagnosing it. The interferon gamma release assays do not give you the answer if the problem in the eye is related to active TB. And some phenotypes are more suggestive than others, and they require less evidence for you to initiate treatment, especially serpiginous-like and occlusive vasculitis. Specific therapy combined with steroids because you want to prevent paradoxical response. And remember that some large choroidal granulomas that are failing to respond very well to treatment may respond to anti-VEGF, as published by our president, Professor Gupta. When do you retest the uveitis? If the pattern of disease has changed, and then if it doesn't fit what you're expecting, or the results of the test are contradicting sound clinical judgment. So I know you're going to be discussions about birdshot later on, but have an HLA-29 positive and concluding that a uveitis related to a scar in the back of the eye is birdshot is incorrect because that test does not fit the phenotype expected for a condition of birdshot. But there are situations when you get stuck. So this slide here shows you very well the same individual with three different pathologies. There's CMV retinitis, there's cryptococcus choroiditis, and tuberculous choroiditis. So when you have a situation like this, the diagnosis clinically may be very difficult to establish. And this is from my friend André Cury in Brazil, is one of his HIV patients. So these situations, we are forced into indicating a biopsy. So if diagnosis not established, there's no response to treatment, there's further deterioration despite therapy, or exclude the possibility of malignancy or infection. This is a case which could be a viral retinitis. The biopsy showed it to be toxoplasma-related retinitis. So this is the one we always worry about, which is lymphoma with its various different presentations, and this is the one that biopsy is necessary for the diagnosis. Keep in mind that vitritis can be very prominent, but usually not associated with macular edema in lymphoma unless the patient has been previously treated. Stop steroids at least for a couple of weeks before you obtain your biopsy, and you can try to take vitreous samples or subretinal sample, processing that sample rapidly, and don't forget that the lymphoma in the eye, you need to make sure you're excluding lymphoma in the brain. Imaging very briefly here, the importance of using imaging to help us with the diagnosis. The angiography was showing you the fact that choroidal pathology can be silent, and without looking at the choroid more specific, especially with an ICG, you may miss that. And the vasculitis is important because you can then define the type of vasculitis, which vessel is involved, how severe it is, if there is absence or presence of occlusive disease. So these are some examples here of how helpful it is in birdshot when you can see disease activity and you can see the multiple areas in which the disease is affecting choroid and the retinal vessels. And sometimes it helps you define between lesions which are typical of the birdshot, which may and do not represent necessarily active disease. I won't mention here, but there'll be discussions later on in which birdshot has a different behaviors, and the lesions may mean different things in terms of the stage of the activity of the disease. So this is a patient just showing you this here because, again, the relevance of imaging. This is a patient who presented with, if you take just a 45-degree photograph, you miss a lot of stuff. So wide field images are very important in defining the extent of the disease and sometimes help you make the diagnosis. Again, examples of the importance of wide field images. And again, the OCT, the relevance of that in looking into the choroid and identifying lesions. So I'm going to skip a little bit here because time is running and to show you some other examples. So very quickly into management and infectious uveitis, you treat appropriately with antibiotics. You always make sure the infection is treated adequately. In viral retinitis, you only consider the use of steroids after 24 hours following full local and systemic therapy. In other infections, it's possible, and you should many times start the steroids alongside the treatment, like in toxoplasmosis, syphilis, and TB. In fungal infections, you do not use steroids, and always be aware of immune recovery reactions which happen in association with previous infectious processes. When you go for non-infectious uveitis, we have to identify, if possible, the cause of uveitis, again, back to the basics, and we want to prevent recurrences because the more recurrences you have, the more damage you result. You want to prevent visual function loss, not only visual acuity. You want to prevent and treat complications and avoid collateral damage as much as possible. So the strategy is what we discussed before: identify location, the severity, because that will dictate how aggressive you'll be also with your treatment. And keep in mind the general health and age of the patient in all cases. So the options we have for local, the topical just for anterior disease, but the perioculars have been largely abandoned in favor of intravitreal injections. And I think periocular has a role mainly in patients who are aphakic these days. And systemic therapy with steroids being our fire extinguishers can be delivered in different ways, and then immunosuppressants and biologics. So take into account all these factors, both in terms of clinical factors and other factors, bilaterality of the disease, location, severity, and look at the general health of the patient and the compliance factor, which is very important in the management of our patients. Local therapy is very useful in unilateral or asymmetric disease, but can be used as an adjunct to systemic therapy as well in bilateral cases. The eye is the only reason for treatment that favors local therapy. If there is a contraindication or intolerance to systemic therapy, in certain uveitis entities may respond more favorably to local therapy. These are the options we have for the local use of treatment, going for our periocular injections, I mentioned already, the intravitreal devices and injections that have been very widely used. We all remember very well the use of triamcinolone, and especially with the introduction of the non-preserved ones, preservative-free ones that were proper for intraocular injection, we benefited more from that approach. The use of Retisert was the first device created, which generated good response, but also lots of potential problems, especially glaucoma. And we could see very well we had a significant impact on the recurrence of the patients who received the implant. Ozurdex, widely used for different reasons, and uveitis, and it's been very helpful in controlling disease because the indication is for active disease. The fluocinolone acetonide, which is indication is not for active disease, but for prevention of recurrences of uveitis. And remembering that the dexamethasone implant does not last for very long, 3-4 months. It's not 6 months as originally thought. And in case of good responses, you could consider the use of fluocinolone acetonide, keeping in mind that you cannot promise the patient that the response to one will equal response to the other. There are different steroids, different release rates. I do not think that local therapy has a role in choroidal inflammation, which is primarily choroidal, and I think it can be used as an adjunct alongside systemic therapy in some patients, such as birdshot. Just a reminder also that our local therapies that are long-acting may result in complications such as CMV retinitis, so we need to be very mindful of these problems. And just to finalize here, the systemic therapy options, we have many alternatives as targets for therapy, starting with our cascade of steroids first, including usually antimetabolites, and then T-cell modulators. But more and more, I think biologics are gaining the upper hand in terms of the indications and are more frequently used. The alkylating agents are more historically mentioned here, still used sometimes, but very, very infrequently these days. Steroids, adequate dose, just hit it hard. Don't use low dose, small doses, because you will not achieve your outcome. And you can use intravenous if necessary in more acute presentations. Just make sure you want to reduce the steroids as quickly as you can. And that's one of the major problems. They're used for far too long and not enough medication. So you achieve a lot of side effects and not the benefits you expect. The immunosuppressives are very helpful in sparing the corticoid problems and helping control disease, usually with the lack of disease control with steroids, or the dose necessary is too high, or disease is frequently relapsing on the use of steroids. These are the ones that are most frequently used, the antimetabolites especially, and of course the T-cell inhibitors are still available, but less and less used these days. And as I mentioned before, the alkylating agents. The problem with immunosuppressive agents, they can be limited by their side effects, and they need expertise in monitoring them. So the key points in this immunosuppressive therapy is that your second line, they spare the side effects of the steroids. There is limited data from randomized clinical trials, but that limited data suggests the effectiveness of these agents is very similar. Finally, biologic therapy, we're all going more and more into that. They're gaining favor, and they're becoming very useful, not only for us, but of course in all areas of medicine. And these are the ones we have been more familiar with, especially adalimumab. Clearly, many targets exist, and more strategies are appearing, but the experience with those in ophthalmology is limited. So the systemic therapy spare the use of steroids, conventional immunosuppression, no significant difference amongst the different agents, maximize the dose of those agents before you jump to biologics, and the biologics are certainly getting more and more used. But remember, anti-drug antibodies can develop and limit the usefulness. Managing of CNV-associated inflammation is mainly remember that combining anti-VEGF with steroids is the best way of preventing recurrences, and there's no need for a loading regime in this. This is just the papers supporting these statements I made. Patients hate taking tablets, they feel well without them, they prefer less visits to the hospital, no need for regular blood tests. So quality of life plays a role in our decisions on how we treat our patients, and we need to listen to them. In conclusion, we need to make sure we have a balanced decision, taking into account the diagnosis of the syndrome you have in front of us, the anatomic location, the severity. Don't forget the patient as a whole, and keep in mind that sometimes combining approaches may result in better control with less side effects. Thank you.
Fantastic. Thank you very much, Carlos. And we'll have a series of opportunities for questions at the end. So let's move on to our cases. So each case will be presented by one of the fellows working with the professor, and the two combined will be about 15 minutes totally. And so we'll begin with Sophia Andrudi's case. Sophia is a very distinguished specialist, very well known in Europe, practicing at Thessalonica in Greece, and associate professor there. And we're very pleased that she's agreed to share her expertise with us. And her case will be presented by Catherine Lazari.
Thank you, John. So, Catherine?
Yes, I'm sharing my screen. Do you see the slides?
Yes.
Catherine, all
Okay.
good.
So, good evening, everyone from Greece. Allow me to introduce myself. I'm Katerina Lazari, and I am a specialist ophthalmologist and a fellow Professor Androudi. Today, we're going to discuss about fungal posterior uveitis. Our case is a 57-year-old man who was referred to our care due to a severe posterior uveitis. As you can see, posterior segment view was very hazy, but we could appreciate white fluffy masses and a string of pairs in both eyes. A strong clinical suspicion of fungal endophthalmitis was then raised. Our patient was a chronic diabetic. Upon questioning, the patient disclosed a known fungal genital infection and a recent urological procedure of renal calculi removal about a month ago. Moreover, he mentioned that he was still wearing a J-stent urinary catheter after the urinary procedure. We immediately proceeded with blood and urine cultures. Under the infectious disease specialist consultation, the catheter was removed and sent for culture, while intravenous fluconazole was started. At the same time, we proceeded with bilateral pars plana core vitrectomy and intravitreal injection of amphotericin B at the end of the surgery. The cultures of both urine and stent catheter were positive for Candida. However, vitreous cultures were negative for fungi. This is how the eye looked like immediately after the core vitrectomy. The foci are still present, as we didn't want to exert traction by detaching the posterior hyaloid and tear the retina. These are the OCTs of both eyes. You can appreciate that the posterior vitreous is still attached. In the right eye, there is a foci right at the center of the macula, coming from the retina or the choroid. We actually cannot tell exactly the borders due to the shadowing. In the left eye, there is a severe secondary focal retinal detachment. And because we were not happy with the first result, we went back in and completed the PPV with posterior vitreous detachment and intraocular administration of amphotericin B. In the left eye, we also placed silicone oil to avoid a tractional retinal detachment. And this is how the eye looked like after the completion of treatment. And distraction of the ellipsoid zone and the overall retinal architecture, along with an increased retinal thickness, were evident. A strong ERM formation at the site of the heat fungus invasion is also noted in both eyes. This is the final picture of our patient after membrane removal in both eyes. The patient underwent 4 additional bilateral intraocular injections of amphotericin P, apart from the systemic fluconazole. However, there was a great improvement in the retinal thickness. Visual acuity has a disappointing result with 20/200 in both eyes. And now we're switching gears and we're moving to the theoretical knowledge of fungal endophthalmitis. There are two types, exogenous, which is caused directly from an external source, such as keratitis, trauma, or intraocular surgery, and endogenous, which arises from hematogenous seeding of pathogens during fungemia. This table shows the most prevalent risk factors of endophthalmitis. Endogenous endophthalmitis, either bacterial or fungal, accounts for up to 20% of all types. It seems that the incidence of fungal endophthalmitis is higher in tropical countries. Moreover, at least 50% of them are due to fungus. The causative organism varies according to the mode of infection. Generally, Candida is the most common cause of endogenous fungal endophthalmitis, fungal by Aspergillus, which causes more severe inflammation. Fusarium endophthalmitis is mainly secondary to keratitis, while Aspergillus usually follows a trauma. Infection spreads during fungemia that may be transient. It reaches the eye through the blood, and especially the choroid, due to its increased blood flow, and it manifests in the posterior segment as chorioretinitis. Then it progresses to involve the retina and vitreous. The predisposing factors for endogenous fungal endophthalmitis are mainly immunosuppression, urological invasive procedures, urinary tract infections, diabetes, and indwelling catheters. And how does diabetes promote the infection? A possible explanation is the dysfunction of blood-retinal barrier permeability caused by diabetes. Moreover, the elevated urine glucose levels contribute to the growth of microorganisms. The predisposition of urological procedures to endogenous fungal endophthalmitis could also be explained. An occult lower urinary tract infection may coexist before the procedure. There is mechanical trauma due to the procedure itself, and moreover, the catheters used also contribute to the fungal invasion. The symptoms of endogenous fungal endophthalmitis include vision loss and floaters, which are usually bilateral. Ocular pain and red eye are less common in endogenous versus exogenous endophthalmitis. To distinguish a bacterial from fungal endophthalmitis, we carefully search our patient's history. Bacterial endophthalmitis is associated with a recent ocular procedure, is more common, and it has a rapid progression versus an indolent course in fungal. Lesions of bacterial endophthalmitis are more diffuse, while fungal carries the characteristic choroidal mass, which projects into the vitreous and is accompanied by an overlying vitreous haze with a typical form of string of pearls. According to this study from China, there were 17 cases in 12 patients of endogenous endophthalmitis after minimally invasive upper urinary tract calculus removal. The patient's ocular symptoms manifested from the day 2 to 22 post-surgery. Patients reported floaters and blurred vision, while the redness and pain were absent. The ophthalmoscopic appearance of endogenous Candida endophthalmitis is characterized by one or more white lesions located mainly in the posterior pole with an overlying vitreous inflammation and vitreous exudates in the form of string of pearls. Early lesions may be flat in the choroid, but progress by protruding into the vitreous cavity and may lead to the appearance of intravitreal puff ball abscesses. Multimodal imaging is very useful for both diagnosis and follow-up of endogenous fungal endophthalmitis. In FA, there is hypofluorescence of retinal exudates with surrounding hyperfluorescence due to capillary leakage. In OCT, the lesions are hyperreflective, while in B-scan are echogenic spots nearby the retina. Endophthalmitis is a clinical diagnosis supported by blood, urine, and vitreous cultures. At this point, we should stress that we should always suspect endogenous endophthalmitis in cases of older or immunosuppressed patients, especially if they were hospitalized in ICU or had indwelling catheters. This table demonstrates the results from the study we have showed before from China. It's impressive that only 4 out of 12 patients had positive blood cultures and only 3 had positive urine cultures. It shows that vitrectomy samples are more sensitive since 10 out of 12 patients isolated Candida in vitreous cultures. Moreover, we noticed that there is a high frequency of diabetic mellitus in those patients, and we also noticed that negative cultures do not exclude the diagnosis, since 20 to 30% of the endophthalmitis cases are culture negative. The cultures must be kept for at least 4 to 6 weeks to ensure that fungal organisms are not missed. And the PCR test is a rapid way to differentiate quickly between bacterial and fungal infections. We have to be very careful in the diagnosis of endogenous fungal endophthalmitis, since 50% of them are misdiagnosed as uveitis, and they are treated with corticosteroids that further aggravate a fungal infection. It is essential to obtain a systematic history before the diagnosis of uveitis is made, especially the history of fever and the recent invasive procedure. According to the Infectious Disease Society of America guidelines, endogenous fungal endophthalmitis treatment include systemic agents alone in chorioretinitis, the addition of intravitreal antifungal injections in macula-threatening chorioretinitis lesions or endophthalmitis, and the addition of vitrectomy in endophthalmitis cases with significant vitritis. In all instances, the duration of the systemic treatment should be at least 4 to 6 weeks, depending on the anatomic resolution of the lesion. Intravitreal injections can be repeated after 72 hours. The prognosis of endogenous endophthalmitis is generally worse than exogenous due to the compromised immunity of the patient, the initial involvement of the posterior segment, and the fact that aggressive pathogens are being involved. Here are some take-home messages to highlight some points. Endophthalmitis is a medical emergency, and prompt diagnosis and treatment are essential for saving vision. Candida is the most common cause of endogenous endophthalmitis. A team approach of both ophthalmologists and infectious disease specialists is essential to ensure the most efficacious outcome. Any unknown progressive ocular inflammation in immunocompromised or intravenous drug abusers should be considered as fungal endophthalmitis. Diabetes mellitus is a strong predisposing factor for endogenous fungal endophthalmitis. Ocular inflammation with fever and recent invasive procedures should direct us towards endogenous endophthalmitis. And a screening fundoscopy examination in all candidemic patients might prevent some cases of endogenous candida endophthalmitis. Thank you very much for your attention.
Thank you, Katerina, for this great overview of this sight-threatening entity. As you already said, to recap, diagnosis is clinical and is challenging as patients are often asymptomatic, especially at the initial stage of the disease. Blood cultures may be negative, and of note, even with a negative blood culture, a patient with characteristic findings suggestive of fungal endogenous endophthalmitis is still presumed to be in the setting of transient or intermittent fungemia and should be treated with antifungals. In the event of vitreous involvement, we use intravitreal amphotericin or voriconazole. Which one? Liposomal amphotericin for macular involvement. I would use either liposomic amphotericin or voriconazole, but I prefer liposomal amphotericin as it has longer half-life in vitreous humor. But it's difficult to prepare. Usually we give 5 micrograms per 0.1 ml. There is a JAMA paper that reported 3 cases that they gave up to 500 micrograms. The fungal healed, but it was toxic. I always prepare the solution myself, and I always examine the color. It should be colorless, not yellow. If I produce an amphotericin solution that it's yellow, I throw it away. We have to remember that prognosis is usually poor, and the final visual acuity is associated with the initial visual acuity, as in our case, the periretinal membrane is likely associated with a poor visual prognosis. Also, there is a so-called debate on whether we should use steroids. And when I hear that, I said, okay, for me, steroids is an absolutely no in these cases. Even if we use local steroids in the form of topical drops, it may come back. So I never use steroids in such cases. I don't know what are the other panelists' opinion on that, but I would like to hear your thoughts.
Well, Sophia, several years ago,
Mark, your voice is echoing.
Several years ago, I had a patient that came to me with a candida endophthalmitis, and that patient had received steroids intravitreally because they thought it was an inflammation. And despite 3 vitrectomies to remove everything I could find inside the eye, there were always small foci of candida. And we used voriconazole, we used amphotericin, we used also fluconazole, and nothing ever worked. It was always coming back. So I agree with you. In a fungal endophthalmitis, I never use steroids until I'm very sure of what the diagnosis is, because I think in steroids, it's the worst thing you can do.
I totally agree with you, Mark.
Okay. Well, thank you so much. And we will have a chance for additional questions. And you can also type questions in the Q&A as we go, and we'll try to answer them as we go forward. So case 2 is Mark de Smet's case presented by Charlotte van Meerwijk. I apologize if I'm not pronouncing it correctly. Mark is our secretary of the IUSG and super involved in all of the work that we're doing, just about everything, along with Vishali, our president. He was initially head of the clinical division of the Laboratory of Immunology at NEI, and then department head and professor at the University of Amsterdam for 10 years, and has gone on to found the Microinvasive Ocular Surgery Center in Lausanne, as well as developing technology for improvement of retinal surgery. And he is extremely well published and knowledgeable, and I'm very grateful, Mark, for your agreeing to present today. And your case is sort of an interesting contrast to the case we just heard. So why don't we go ahead and have Charlotte present that case, and we'll proceed.
Thank you very much. Today, I'd like to present 2 challenging cases about endogenous endophthalmitis. And I'd like to start with the first case, but first we had the 2 major challenges with these cases. We had to establishing the diagnosis and also to identify the source, what was also mentioned earlier. Case 1 is about a female patient. She was 60 years old and had a chronic pancreatitis, also COPD and hypertension. Recently, she had also an embolectomy of her lower left leg with a post-bleeding, and also started with a systemic treatment for lung carcinoma. So she had a immune-compromised status. 2 months later, after starting her systemic therapy, she developed central cotton ball-like spots only in her right eye, with the diagnosis of the BRVO of colleagues of us. And also she had a central edema and a pale retina. Her left eye was totally normal and her vision was also good. And 1 month later, she developed vitritis in her right eye. Then they started with oral prednisone, and they stopped the immune modulating therapy because they thought maybe it's an inflammatory reaction of the start of her immune modulating drug for her lung carcinoma. And they started another potent therapy for her lung carcinoma. However, after starting her systemic prednisolone, the vision increased, and however the vitritis getting better, but the cotton ball spots or the white lesions they saw in the center were increased and recurred, and also the vitritis recurred when tapering the oral prednisolone, and that is why the woman was referred to an uveitis specialist center. And this is the image what we saw. This was the right eye, and this was the left eye. And on the right eye, you see dense vitritis in the center, and also multiple white yellowish lesions around the vessels. And it also progressed over the week. So we saw quite quick increasing of the size of these lesions. So we thought this could be an infectious cause, and maybe it's bacterial because you had a fast increasing of the size. This was an OCT, and the most involvement we saw subretinal, so we thought. And we performed diagnostics, the screening. We did an chamber tap for the PCR and the Goldman-Whitmer for the viral and toxoplasmosis, but they are all negative. And then we performed a diagnostic vitrectomy, and I had a quick movie about it, and I think that's really interesting to start here. I just skip here. Here you see a lesion, but when we are operating, we thought, hey, this kind of lesions were pre-retinal, and we thought it was just subretinal. So we moved it, and then we collected for further diagnosis to the pathologist, as you can see here. And in the end, you see that it was a highly inflamed eye with a hyperemic conjunctiva and also synergia in the center. Diagnosis were performed of the biopsy that we did. We looked at the viral, but also bacterial causes, fungal causes, and also lymphoma was in our differential diagnosis. The PCRs were again negative. The cultures were and remained negative. Kleptomenin were negative. Diagnostics for lymphoma were also negative. But in the piece we collected and sent it to the pathologist, we saw one Candida strain, as you can see here. So we started with therapy. We performed one intravitreal amphotericin B injection and started systemic fluconazole for 8 weeks. We did that because we searched for the focus systemic, but we didn't find any focus. Cultures of the blood and also the urine were negative. The infection was controlled, but the vision was unfortunately not improved because the central location of the lesions. This was case 1, and I like to present another challenging endogene endophthalmitis case, and that's this one. Case 2 is about a 69-year-old man and currently recurrent from Gran Canaria, where he felt a little bit tired with reduced appetite. Presented to the hospital within 3 days or history of decreased vision with light perception vision, fibrin in his anterior chamber. His lens was intact with moderate cataract, and the fundus was could not be investigated because of the dense fibrin and also the cataract. So also diagnostic vitrectomy was performed, and the samples that were collected was sent to, we did the Kiemsa staining cultures and also sent to the pathology. The fundus during operation showed presence of multiple hemorrhages, extensive sheeting, and 2 disc diameters of white infiltrate next to a vessel. And based on this, this image and the situation, ceftazidime and vancomycin intravitreal was given with the suspicion of an infectious cause, and also quinolone intravenously was started. First day post-operatively and also after starting the treatment, there was already less discomfort but more hypopyon. But the second day there was a decrease in hypopyon and also less inflammatory signs. In the end, the microbiology reveals that it was that there was a presence of the Streptococcus milleri, and then is the important question: what is the reason that this patient developed his endogenous endophthalmitis with this bacteria? There is, and that is important to look at and to search for a primary cause or primary focus. There is also in the literature presented that the presence of developing an endophthalmitis, an endogenous endophthalmitis, can be secondary to solid tumors. As for example, the neck of the head of the breast. So there was also diagnosis done in this patient, and in the end, there was a colon carcinoma diagnosed, and probably that could be the reason that the bacteria was spreaded in his body and then causes his endophthalmitis. Also, there are publications about the gut microbiota and the role in colon cancer, and maybe there is a role for the bacterial that the bacterial protein toxins can play a role in developing the colon cancer. Next to that, the Streptococcus endophthalmitis can also be associated with endocarditis. That is the most common reason for the endogenous endophthalmitis due to Streptococcus. Also, the arthritis is seen, and the other causes are less common. The endogenic endophthalmitis accounts just for 2 to 8% of all endophthalmitis cases. Most endophthalmitis cases are caused after operation, but it is important to distinguish and also to search for the etiology. A significant risk for bilateral disease in 15 to 25%, and it is depending on the series that are presented, but diabetes is presented in more than 50% of the cases, and it is also more an issue in the cases of studies from Asia. It is related to cancer, what I also presented before, in 12 to 33% of the cases, but also you can imagine that patient had cancer, had also treatment. So due to chemotherapy or cathedral, because of the treatment, they get also immune compromised. So that is another reason that they are more vulnerable for this kind of endophthalmitis development. And also the intravenous drugs use are seen as a risk factor in 8 to 43% of cases. The bacteric disease, there is a large study published in 2019 in the US, and they retrospective analyzed a large amount of bacteremic inpatients patients, and how many patients and who developed the endogenous endophthalmitis. Most common cause was the Streptococcus species. Also the Staphylococcus aureus were seen, or E. coli. And as risk factors, they published the presence of a prostatitis, the bacterial meningitis, pyogenic arthritis, organ abscess, also endocarditis, what I also mentioned before, osteomyelitis, diabetic retinopathy, and vascular catheteral placement or infection. This is another study, and it's also a long list, but to summarize, there are all reasons that a patient can be vulnerable and also be immune compromised due to what they have, what their systemic health, what this health status is. This is about the fungal endophthalmitis, and in 90% of the endogenous fungal endophthalmitis, where one or more underlying medical conditions seen. And in 21 to 70% of the cases were secondary to malignancies or cancers, and 15 to 29% were secondary to intravenous drug use, and also 29 to 38% secondary to general surgery. And also, as a note, that the subject's diagnosis with fungal endophthalmitis caused by mold species were in higher proportions in history of the iatrogenic immune suppression, whole organ transplantation, or an indwelling fetus line. Our take-home messages for endogenous endophthalmitis. It's very important to ask and try to answer the question, what kind of infection is the cause, and what is the systemic or external cause of source of the infection. And for the diagnosis, there are multiple options to use as a diagnostic tool, but most important for our cases was the pathologists, and they gave us the answer. A broad differential diagnosis is needed and also necessary, and also broad multimodal approach is the best established to have the case done. So thank you very much.
Okay, I think, if you look at our case, can you hear me? If you look at the case, the two cases we presented in the previous one, they sort of contrast one another.
Mark, there is an echo in your voice.
Yes, Vishali, I can't hear you.
Because there is echo in your voice, probably you are logged on to two devices. You may have
Yeah,
to...
we should only have one right now. She just turned off because we have two computers next to one another.
Now
It's good now.
Oh, perfect. Okay. So we chose these two cases because in some ways they're often what we see. The previous case that was presented with Candida, you had a clear history, you had a good idea of what was going to, you might find, or at least some idea. With these two cases, it was rather unknown. In the first, the pathologist sort of was good at finding the cause, the Candida. None of the cultures were positive, as you've heard before. PCR wasn't positive. And I think the most important message here is whatever you're going to do during surgery, try to get the area where the infection is present and split the sample so that it is given to different people. In many centers, the cytologist is going to do a better job than the pathologist because they're more used to getting very small samples. And if you think of Candida, KOH stain can be useful. The others, you have, of course, to culture for a prolonged period of time, as was done in the case that you've heard from Greece. What I do with regards to endophthalmitis is I place them in blood culture bottles to make sure that if it comes late at night, there's a good chance the bacteria will survive. And we always ask for PCR because very often that gives you a much better diagnosis overall than sometimes even the culture. The second case that I presented, the pathologist, the microbiologist called me and said, does this patient have cancer? And so this was the first time I was ever exposed to a situation where somebody is telling me the potential source from an endogenous endophthalmitis. Most of the time, we don't really know. And that's why we gave you this list here of the most common causes or associations for an endophthalmitis that is systemic with regards to its origin. Now, I wanted to mention something about the post-op course. I mean, if you're going to have an endophthalmitis, the treatment's going to be ceftazidime and vancomycin, as it is in most cases. But you have to realize that ceftazidime is a beta-lactam. It breaks the bacteria, so it releases a lot of inflammatory agents. And so the first day, the inflammation very often looks worse than on the day of the surgery, but the pain the person has largely disappeared. And that's very often an important clue that you're on the right track. Because it's endogenous, you should certainly give systemic medication from the very beginning. And as we've shown you, most of these cases are either gram-negative, they're caused by a strep. And so a ceftazidime is probably a first good choice. And to give you an idea of the dosages, you don't necessarily need a pharmacy that prepares it for you. This is what we have very often in the West. But for years before, I would prepare it myself in the OR. And what you want is to take a vial and get about a solution of 20 milligrams per milliliter of ceftazidime, and you inject 0.1 inside the eye. The rest you can give IV. And your vancomycin is 10 milligrams per milliliter, again 0.1 cc, they inject into the vitreous. And if need be, you can repeat it 2 or 3 days later. I never give steroids at the very beginning. Some people do. I like to first know the diagnosis and be sure that we have an endophthalmitis. When I saw the picture that Charlotte showed me at first, in her case, I thought, well, this is probably a bacterial endogenous. And had we injected steroids, as we discussed earlier, this would have been probably a very bad thing to do for this particular patient. So I hope those 2 cases you found very interesting. I think the key is do whatever you can, spread it in terms of trying to get a diagnosis, and then in terms of trying to find the source. There is more and more data coming out from general medicine and from cancers about these associations with different pathologies, and they can help orient us to the right diagnosis and treatment.
Thank you very much, Mark and Charlotte. Great cases. Obviously, endogenous endophthalmitis will be something that has a big impact on sort of the systemic management of the patient, and it's not necessarily the most common thing you see in posterior uveitis, but we sort of wanted to cover it because we're having a lot of sessions on other more common ones.
I think we lost John. Is it? Okay.
I think momentarily, yeah.
Yeah, I'll take over. So what John was saying is what we are covering here is mostly endophthalmitis and bloodshot, because we would be taking care of other individual entities in posterior uveitis in different webinars, topic-wise. And with this, I would like to invite now our next speaker, which is Tigani. Is that right? I'm sorry if the pronunciation is not right. And he's fellow with Janet Davis from Miami. And the topic which they will be discussing is birdshot retinokeratitis. And everybody knows Janet Davis. She's the past president of IUSG and a very well-known professor in Florida. So I'm not going to introduce her. Over to you. I'm sorry, I probably saw the last brochure. So presenter is Aranico. Aranico Pandey. Sorry, Aranico.
Hi, everybody.
So can I request everyone to please put themselves on mute? Mark, can you please mute yourself? Okay, perfect. Over to you, Aranico. Apologies for the...
No, that's okay. Thank you so much. Dr. Degani is my colleague. Hi, everybody. I'm Aranico Pandey. I'm the UVEITIS fellow at Bascom Palmer Eye Institute. And my topic of presentation today is birdshot choroidal retinopathy, acute phase, and my faculty discussant is Dr. Janet Davis. So we have a 37-year-old female patient who presented with floaters in both eyes and difficulty driving at night for the past 2 months. She was a referred patient, and at the time of presentation, she was already on 30 milligram of oral prednisone, which was tapered down to 20 milligram. She briefly came in for imaging test, and this was her first in-person visit. Her images were remotely evaluated, and she was already on mycophenolate mofetil 500 milligram twice daily at the time of her visit. Her vision and pressure were normal at that time. Anterior segment findings were non-contributory except for a 1+ anterior vitreous cells in the right eye. This is the color fundus photograph of the right eye and the left eye. I want to have your attention to yellow round choroidal lesions in both eyes, some of them taking configuration of a linear spinal shape lesions, whereas others remaining as tiny yellow round lesions in the periphery. This is the fundus autofluorescence of the right and the left eye, where you can see a particular pattern of perifoveal mixed kind of hyper and hypo granularity in the hyper autofluorescence that you can see over here in both eyes. And this also aligns with the OCT macula image of the right and the left eye over here, where you can also see kind of perifoveal loss of the outer retinal layer with disruption of the ISOS junction and deposition of the hyperreflective material in the RPE. Also, there is hyporeflectivity of the chorea capillaris that you can see over here. So this is the fluorescent angiography of the right eye, showing the early and the late phases, where there is particularly large vessel leakage of the veins, sparing the arteries, also leakage of the optic nerve. The pattern is similarly seen in the left eye. This is the ICZ angiography, where you can see diffuse hypocynosine small round lesions in the macula as well as in the periphery, which is also present in the left eye. So the UVEITIS lab workup was negative for everything except for a positive HLA-A29 antigen. And the diagnosis of bird-shot chorioretinitis was made, and her mycophenolate was increased to 1 gram twice daily. She was asked to taper off the prednisone. She was having side effects of anxiety at this time and was asked to consult a psychiatrist. So she followed up a month later, and at this time, her vitritis was still there. She was tolerating the mycophenolate pretty well, and now it was increased to optimum dosing of 1.5 gram twice daily. She then presented again 2 months later, and at this time she was worsening with increased vitritis. This was her FA, which shows persistent vascular leakage and persistent bird-shot lesions prominent in both eyes. Now she was advised for intravitreal dexamethasone implant, but unfortunately she could not afford it, and so she was started on prednisone 30 milligram. So at this point she was taking escitalopram in consultation with a psychiatrist and was asked to continue the mycophenolate. So let me take a break and present some other cases that we saw in our clinic for bird-shot chorioretinopathy who had like variable response to treatment with steroid. So this is our first patient, who was a young female who had an underlying high risk for malignancy, and she was injected with intravitreal Ozdex in the right eye. And this is the picture after ICG after 2 months after injection, with resolution of the lesions in the right eye, but persistent in the left eye, which was not injected at this time. Later, after injection, there is resolution of the lesions in both eyes. So this is after 9 months in the right eye and 7 months in the left eye with reappearance of the lesions. So this is another case of a female patient with bird-shot presenting with vascular leakage of the large vessels seen in this FA picture at the time of presentation. She was prescribed with 60 milligram of prednisone, and this is the FA after 2 weeks in prednisone, where you can see decrease in the vascular leakage. So now moving back to our patient. So at this time, the patient followed up after 2 months, and she started to improve with decreasing vitritis. She was tolerating the medicines well, and her prednisone was 15 milligram, which we asked her to taper it down to 5 milligram in the coming 6 weeks and to continue the mycophenolate. So finally, she presented again after 2 months. At this point, her vision was slightly improving, but she had persistent vitritis. There was persistent leakage of the large vessels in FA, and the bird-shot lesions were still present in both eyes, as seen in this ICG photograph. And now she was asked to increase the prednisone, to 30 milligram for the third time, and asked to taper it to 7.5 milligram in the next 2 months. and she was asked to continue the mycophenolate, and now she was added the adalimumab. So I want to conclude my presentation with this serial OCT imaging when she presented with this outer retinal layer with ISOS disruption. When she was like a worsening when at the 6 to 8 months, when she was already around like 5 months on mycophenolate. She started to improve with resolution of the ISOS junction that you can see over in the picture. So thank you. Now I want to hand it over to Dr. Davis for discussion.
Yeah, thank you very much. So this is completely different than the cases that you have had previously seen today. It's not an infection. It's not an unknown. It's not rare, at least in European countries. I think it's rare elsewhere. The host has disabled my screen sharing capability. So if someone could fix that, please. Okay. Great. So it's also not a short-term disease. So like all of the other two cases that we had, you know, once you have the diagnosis, things are going to go well. And in general, things are going to be very manageable. However, we're not going to concentrate on this brief discussion in terms of diagnosis, but instead talk about the natural course of disease during treatments and the implications that has for vision, because this is a completely different type of disorder that can last 20 to 30 years or until the end of life. Very significant. I'm very concerned about this young woman that was just presented because she has a severe form of presentation where there's already a lot of outer retinal change at the level of the retinal pigment epithelium, as you could see on the autofluorescence, which is usually not disturbed in early stages of disease. So there's some generalizations that can be made about birdshot. It's usually in middle-aged people. I think if a person is younger when they present, like this woman in her 30s, it is worse and more active. If someone comes in with some symptoms for a while, but they're in their 70s, it's usually a much milder presentation. It's usually an insidious onset, but it can be acute, as in the case that Dr. Panby presented. And then also, I think it's worse. It can present in a chronic phase. It's generally, I think, a very slow disease, except when you have these acute presentations. As I said, it's generally lifelong, but even with that, sometimes it can spontaneously remit. And if you treat them for long enough, sometimes you can get patients to enter a drug-free remission. I'm beginning to think, the longer I go on, that this is relatively rare. Usually we select systemic therapy on the thought that this is an autoimmune disorder, but dexamethasone implant is very helpful in the short-term induction phase at the onset of treatment. And then maintenance with a fluocinolone implant works great for chronic treatment. And because we're not going to do a whole lot of didactics here, but just show more illustrations of the disorder, I want to call the attention of the attendees to this review article, which is recent and also available online. You can read the full text. It's been provided to you. So copy down the PubMed ID and please read it. It's really quite excellent. And Dr. Brazan is a specialist in the area of birdshot. So there's one case of histopathology. It gets shown a lot. And we know that there's both choroidal, retinal, and perioptic disease. Nobody knows what is the most important. I think there's some differences in terms of what is important for the outcome of the patient. I think this is a choroidal disease, and I always refer to it as chorioretinopathy. I think the retinal vasculitis is important because you get vascular narrowing, but I think the true visual prognosis comes if the choroidal disease is not controlled. Here's another way to look at the histopathology, which is OCT angiography. Please note that the whole retinal scan of the vessels here looks impaired. That is shown on the structural scan as well. There is a low-lying macular edema, a very chronic appearing eye. There's this hyporeflective choroid that we've mentioned. And you can see the flow voids here on the SDOCT, and also abnormalities on the structural scan. And you see the same type of abnormalities in the choroid. So conventional angiography in birdshot is as follows, and this was shown to you by Dr. Pandey. She was untreated at presentation, relatively mild presentation. Sort of by accident, we got another angiogram 2 weeks later after she was on 60 milligrams of prednisone. This is a later stage of the angiogram, so it looks a little bit worse. It's really, I think, it's just the same as it was, but you can see that the birdshot lesions have really responded. And this goes back to my point that retinal vasculitis aspect of birdshot is more of a damage type of problem, and the choroid is more of a dynamic inflammatory process that must be controlled. So this is another case that is more similar to the case that Dr. Candy showed coming in, acute presentation. We see stabilization of the fluorescein during long-term treatment, but the fluorescein angiogram also remains active with many lesions. Whereas in Dr. Pandy's case, the patient was treated with very low doses of prednisone because of her anxiety disorder. In this case, the woman was treated with full repeated courses of high doses of prednisone according to the ADVISE trial. However, these courses are always tapered. And so at this point, well into the trial, 9 months of intensive treatment with courses of prednisone, she's on 2 immunosuppressive drugs and has been transitioned to biologic, and she still has active disease in the choroid. I think that we would not know this were an ICG not done. So at this point, the emphasis changes. Here we have a patient who's in the mid-phase of treatment, and now I begin to be worried about pigment depigmentation. Because of this is chronic degenerative disease in birdshot. This is a patient who has had birdshot for probably 20 years. She came in very late, already with damaged maculas and pigmentary changes. You can see the attenuation of the retinal vessels, the optic nerve pallor, and the extensive pigmentation. Interestingly, at this point, FAICG is no longer useful. You can see scarring, but you don't see active infiltrates, which is why I refer to this as a degenerative phase. You really hope you did not get to this point. And at this point, the focus switches to autofluorescence, where you can see the damage in the RPE and the full thickness atrophy as well. And this can become very advanced and very disabling for patients. We also see choroidal structure, as was mentioned. You initially would just see that the choroidal vessels look more prominent. There's an increased luminal area, but then you can get a diffuse hyperreflectivity and thinning. And we actually looked at this, and the rate of choroidal thinning in birdshot is greater than in normal controls. This is an age group usually where the patients are also undergoing aging changes, and I think that this is also quite damaging. So to sum up on this, in a long-term follow-up choroid cohort, I am associating progressive choroidal depigmentation that in most of the patients who were treated for at least 5 years, and also correlating this with vision loss, which generally is slow, but if there's severe vision loss, it's related to choroidal degeneration. And thank you for your attention. And if there are any additional questions or comments on this.
Janet, I have a couple of comments, if I may. It was very interesting, the very first presentation of the slide showing those outer retinal changes in birdshot, even in the acute patients. I have a lot of birdshot in my clinic. It's very uncommon to see that. This loss of the ellipsoid and all that. This is not a very common feature of that. You see a lot of inner retinal edema and as a consequence of the vasculitis. And those changes tend to be, as you described very well, later on as the choroidal pathology is poorly controlled, then the outer retina gets more and more involved. And your autofluorescence very clearly shows that when you follow them up. So it's an interesting acute presentation, which is uncommon to see that in the very early stages.
I agree. This was reported by Deborah Goldstein. So it is a recognized feature, and I think it has a poor prognosis. And I think it correlates with the fact that she really did not respond that well to treatment. We were a bit hampered by her inability to use intravitreal injections, which for me is always short term, and also her inability to tolerate higher doses of prednisone in the absence of intravitreal.
The other thing was interesting.
They did.
Go ahead. Sorry.
Oh, no, please.
No, I was going to say the interesting thing is the good response to Ozurdex that you showed, because I have used intravitreal mainly probably Iluvien, and I have seen no impact at all on the choroidal lesions. They look exactly the same. They usually respond well to systemic, but to local, I think there were publications on Retisert also showing poor response of the choroidal lesions to the Retisert. So it's quite surprising to see. One of my colleagues at Moorfields thinks it does work. I've been arguing with him. I don't think it's a good option. And you're showing an interesting response to the Ozurdex, which I haven't found myself.
I don't think I actually showed that. And I actually have looked at a lot of cases that comparing systemic to local therapy. And I think you are completely correct. And I have a couple of slides, but I won't go back to my presentation. But in local therapy, you will often get this progressive choroidal depigmentation. Yeah. My personal opinion, because I don't think birdshot responds to anything that is much lower than 60 milligrams of prednisone. Frankly, it takes huge amounts. I think probably the best approach would be both intravitreal, perhaps a long-acting drug implant, which will not completely control the disease, plus systemic immunosuppression. I think both types of treatment have their role in birdshot. Then, of course, you expose the patient to dual toxicities, both systemic and local, which are not trivial.
Yeah, what I found is that the local is very, very helpful for the retinal vasculitis components of the disease. It really shuts it down very, very nicely. And that probably reduces the burden of the systemic therapy for the choroidal treatment. But I agree that the combined approach, it seems to be a very useful tool in birdshot. I think it's a disease suited for that.
So that's why I mentioned Ozurdex as an induction therapy for birdshot. I think it works extremely well. One of the extra cases that Dr. Pandy showed got Ozurdexes in both eyes by one of my colleagues and was one of those unfortunate patients who got bilateral glaucoma and bilateral cataracts after one Ozurdex. Not common. Usually you can get by with it, but not in this case. And so it can be very harmful to patients.
You know, there was a time when people wanted to treat very lightly when you just saw a bit of choroidal granulomas in birdshot. And I think you have to be pretty aggressive with the systemic therapy. And I agree with both of you that, you know, the use of steroids is good to quieten the lesion. But if you're really seeing that, a lot of vasculitis in the retina, you already have a fairly advanced case. These are patients that have birdshot active for about 4 or 5 years by the time they show up. So, you know, the key, I think, really is the systemic therapy. This is long-term. It goes on for years, decades even, in terms of trying to prevent the progression.
Yeah. So Dr. Pandy's case that he presented was also interesting in that it was an acute presentation in a woman in her 30s. And she was 20/20 throughout that entire course. Her angiography looked horrible. You know, I think it would have been very easy to undertreat this patient. I'm not sure that I didn't undertreat her in terms of taking a long time to get her under control. And she's not under control yet, but we are trying.
But I think that's a very good point, Janet. You know, the vision can be good for years and years, and yet the disease is continuing both in the choroid and the retina. And we get, you know, lulled into thinking we're doing fine because we have, you know, 10/10 vision, 6/6. So, and that's not the basis for birdshot. You really have to get it right.
Right. And if you get rid of the retinal vasculitis in any means, they're going to feel fine. They love their vision. It's excellent. But the choroidal disease of which they are not aware, you have to detect for them and you have to make sure that it gets treated.
Exactly.
So, Janet, there is a question related to that. What would be the best imaging modality for monitoring the signs at different stages of the disease? So can you discuss that?
Well, you know, I understand that ICG is not available everywhere. And in the absence of that, with more data, you might be able to propose OCT angiography to follow the choroidal changes. Even a plain OCT could show you alterations in the structure of the choroid with very ominous signs of hyporeflectivity or thinning. Sometimes it's thick, it's hard to say. And I don't think we have enough data to actually say what you need, what the good outcome measure is in OCT angiography. But try that if you don't have ICG. Otherwise, I use ICG. I don't know how people manage it without that modality. In terms of, I tried to go through, in the acute phases, you look at a FA-ICG. Once they're controlled, you need to monitor for changes on the fundus photography. And in the very late stages, you're concerned about fundus autofluorescence. Although at that point, frankly, there's not a whole lot you can do about it. If they're getting that degree of RPE atrophy, you can comment that it's increasing, but I don't know how you can reverse people once they are in that stage of disease.
Would you rely on electrophysiology, or would any one of you rely on electrophysiology for birdshot?
Electrophysiology, I've been using a lot, as you know, Vishali, and I think it's very helpful because in terms of reflecting the retinal component of the disease, when they're very active, you can show the electric negative B wave, you can show the overall dysfunction of the retina, and you can document the response to treatment very well. But from the point of view of this discussion of a choroid, once you start seeing the A wave abnormal, that's when you start seeing the photoreceptors going and the RPE changes a bit late in the game. So I think it's helpful in monitoring disease response for the retinal vasculitis. It helps you when you're making changes to your treatment to detect if something is modifying without needing to do an angiogram. But I think once you go into this later phase of the disease, it becomes less helpful. It will detect some abnormality, but it's not going to be as good. I agree with Janet. I think ICG, if available, really helps you define if you're controlling the disease well, which is essential for this long-term damage to the outer retina, which will happen inevitably. And as she showed very good severe cases of so much damage to the back of the eye, which is very much a consequence of this change.
I will disagree just a little bit, Carlos, and that I think that probably the ERG is most important in the later stages of disease, as is visual field. As the eye becomes more damaged, and the FA-ICG becomes much less useful. The vessels are either too attenuated to leak, or you just can't see the birdshots anymore because there's a lot of destruction of the choroidal structure. I find the ERG and the visual field to be critical at that point to pick up things that I am not certain about. And
the problem is,
you do need to have baselines.
Yeah, I think the problem you have with that is that, yes, you pick up, once you have a certain amount of damage, it's difficult to get a lot of difference in your ERGs. There's a critical point beyond which the reports don't show you a huge variation anymore. It's so much damage in there, you can't see. I think what I was trying to say is that if you allow the disease to reach a very end stage point, as you described some cases, at that stage, I don't think not even your functional test will help you very much anymore. I think it got to the point when the damage is so huge that you can't reverse or you can't do much. But I think in the early stages, it does help you.
Yeah. I guess I'm not talking about someone as severe as the case that I showed, but in other people. Recently, I did an ERG in a man who came to me already 8 years off of immunosuppression, and now it's 5 years later. And we've done 3 ERGs in him sequentially, and he is actually showing a slow decline in his ERG. And he is not, he's not visually symptomatic. He doesn't have classic signs of inflammation. But I think I am picking up that he is actually still progressing, which is the nature of birdshot, I think. Regardless of what you see, I think it is a degenerative disorder.
I think the idea of being able to do visual fields is also useful because not everybody has access to good ERGs. And ERGs, I think, are a great way to go if you're able to interpret them and have somebody who can do them for you correctly. So, and I agree with Janet that in patients that are more advanced, it can be a good way to follow them. After all, the whole idea here is to be able to stop any progression, even though they're fairly advanced. Never should give
the
up on
ADVISE trial.
patients.
I mentioned the ADVISE trial, and the ADVISE trial is interesting for another feature besides these, these pulses of high doses of prednisone with really long tapers and going back to prednisone whenever you have the slightest blip in inflammation. But the outcome measure that was selected for the ADVISE trial was actually visual field. And, to me, you have to wait so long to get an abnormal visual field. You waited too long. But I agree, it's a good safety net to make sure that your patients are not changing. And in the early stages of disease, there's a very characteristic visual field, which is like an arc coming up from the optic nerve head that corresponds to the infranasal region. And that will clearly improve with treatment. So visual field, if you have nothing, if you've got a color photograph, an OCT, and a visual field, I think you can protect your patients as well as your clinical judgment.
There are two more questions related to electrophysiology, and Carlos, maybe you can answer them quickly. 30 Hertz flicker implicit time for treatment effect. And the second is any role of EOG.
Okay, the 30 hertz flicker we published a long time ago. Graham Holder was working with us at that time. It seems to be the most sensitive marker for activity of the retinal disease component. And so you see the implicit time will be delayed quite markedly in this patient. So if you have someone with a response that is like 30 milliseconds, sometimes 32 milliseconds, these are very delayed responses. And if you treat them adequately, many of these patients can show improvement. But it is a marker of activity that can be helpful in monitoring how the disease is responding to treatment. I think EOGs are not really very helpful. They will reflect the RPE damage that you have. So it's not a particularly very good marker for disease activity, and we don't tend to do them as a standard. I think EOG has its applications, but not in this condition.
I think we have very less time left, so I will quickly take up one controversial issue, and that is intravitreal steroids. Both Sophia and Mark emphasize that if you see fungal endophthalmitis, absolutely no steroids, not even topical steroids after vitrectomy. So my question to you all is that there are studies which have indicated that amphotericin itself is toxic and it should be given along with DEXA. You don't give amphotericin injection alone. So would any one of you like to comment on the use of steroids under your observation once you have started the treatment for fungal endophthalmitis? We are not talking where you are not sure. That we understand that if you do not know the diagnosis, please do not inject steroids. But if you know you are treating under antifungal treatment, would you give low-dose steroids under your supervision? Janet?
Yeah, but because dexamethasone only lasts in the eye for 24 hours, and amphotericin is highly inflammatory. Topical steroids, I will just make a statement. I've never seen any infectious uveitis. Well, if it's not with an infection of the anterior segment, maybe, but posterior uveitis that is infectious, I've not seen it worsen on topical corticosteroids. And even anterior segment inflammation, whether it's keratitis or herpes, is often treated with corticosteroids. Infections cause inflammation, and balancing out the anti-infective with the anti-inflammatory treatment is really important. However, don't inject intravitreal steroids in an eye with fungal endophthalmitis. Okay, this is wrong. Okay, it's not going to turn out well.
Yeah, I think what people need to remember is that the way that you control a fungal endophthalmitis is by stopping the fungus replicating and allowing your immune system to clear the problem. If you block your immune system, you cannot achieve that. So the problem with the use of steroid is that the drugs are fungistatic. They are not fungicidal at the levels that are tolerated by the eye. So if you're just inhibiting proliferation, you that rely on the immune response to clear. And if you block that, then you create a big problem.
And Carlos, there was a question for you, which I thought we will discuss live. The question was, if you have the recurrence of posterior uveitis, which you have treated before, and now has recurred, and the recurrence is more severe than the previous one, how would you approach this patient?
Well, I think here the most important thing would be separating this is an infectious or not infectious problem, because if you're dealing with infectious disease that is recurring, for instance, like TB, very much known to you, Vishali, if you didn't treat TB properly and it was undertreated and it can then present itself again, it's because your treatment wasn't complete, then it's one story. But the issue happens with some of our non-infectious uveitis. We do see that even though we find that we're treating them adequately, and let's say VKH is a good example of that, we start treating them aggressively, and some of our patients will eventually show signs of disease coming back after they've been stopped, treatments being discontinued, which is an unusual behavior. We see that from time to time, and some patients behave very badly. So I think it comes back to the understanding of why they're having it in the first place. I think we don't have good answers for all the conditions we see in terms of the pathogenesis of these diseases and how effective our interventions are in totally shutting them down. So it's possible that we think we're controlling them very well. We still don't have markers that allow us to detect there is still activity that might be going on at levels that we shouldn't stop our treatment, should prolong or increase. So we are happy when patients are clinically better and our markers, as we know them today, show improvement and resolution. But it doesn't mean that sometimes the condition is completely cleared, and they may return as people are querying. What you do is just, if you confirm that you're happy that your diagnosis is correct and you have excluded the things you talked about, infections and masquerade, then it's a question of going back into the strategy of controlling the disease again. And eventually, the knowledge of what happened before will guide you on how much longer you carry on treating these patients after that first event. So the second event may be treated more aggressive or more for a longer period of time.
So now I'm going to ask all of you to give one learning carry home message based on all the three cases discussed. I think I will start with myself till the time all of you are thinking. One very important factor is endogenous endophthalmitis. If you are confused between uveitis, a severe uveitis, and endogenous endophthalmitis, just look at the glow. If the glow is yellow, it's more likely to be endophthalmitis than uveitis. Even the very severe uveitis and vitritis does not produce that yellow glow. So that will be my carry home message based on my personal experience. And now we move on to all of you one by one, starting with Massimo Ecroniti. Like, what would you like to tell our attendees at the end of this three cases? Massimo, unmute.
Can you hear me? Okay. So good afternoon, everybody. Well, I think that the best thing to do, coming back to the Carlos last comment, is that you can expect any issue in a patient with uveitis. So you can visit the patient, examine the patients, and take same amounts of inflammations in the first recurrence of uveitis, but although you think you are treating this patient properly for a proper period of time, the patients can recur, especially if we speak about non-infectious uveitis or idiopathic, as you prefer, and if the patient is not has not any systemic symptoms, so she is purely an ocular problem. You can encounter, it's very frequent that you can encounter relapses with different weight of presentation and with different severe disease. So be in mind that if you have to exclude the infectious disease as we have seen today, you should also mention that posterior uveitis can be caused by different other etiologies, and most of them are unknown, and you can expect and you have to treat them for a long period of time and expect the recurrences and follow up the patients for a long period of time.
Thank you. Rima?
So I think it's very important to distinguish between the infective and the non-infective to begin with. So if we see primarily lesions which are more of retinitis, the retinitis element is more than the choroiditis. I think we are thinking in terms of infectious, whether it's fungal or bacterial, and of course the systemic history. And if the lesions are more towards choroiditis, lesser towards retinitis,
we think of non-infectious etiology. And we shouldn't be in a hurry to start steroids unless we are sure of the etiology.
Thank you. Alejandra?
Yes, always rule out infection. I think is the best, the main message. After having ruled out infection, treat with step therapy is good, and systemic therapy is always important. But also in certain pathologies, intravitreal treatment is crucial.
Mark?
I think we've shown some cases that are quite rare, and I think the most important thing is to realize what do you have in your area, and both in terms of the type of bacteria or infection causes, what they can respond to, and the same with regards to a non-infectious cause. The majority will be related to the region in which you are. And so if you know that, that can be a basis with regards to your treatment. And yes, first we rule out infection, and then we try to treat as if it were a non-infectious uveitis.
John?
In terms of the endogenous endophthalmitis, one of the things that may have been clear from the presentation is there's virtually always some very significant systemic aspects. Either the patient's extremely sick, they have diabetes, they have some sort of catheter kind of thing, like dialysis patients frequently will be ones that develop it, or else they're injection drug users. So those are very important clues.
Thank you. Sophia?
Yes, look at your patients holistically. Endogenous endophthalmitis is a clinical diagnosis. You may have negative cultures. Don't be disappointed if even with a negative blood culture, if you still have the characteristic findings, go ahead and treat the patient, because there might be intermediate fungemia and you might save the patient's eye from this sight-threatening disease.
Thank you. Carlos?
The one thing that I just want to say is that not all patients with endogenous endophthalmitis will be very sick. There are patients who can walk into your clinic with an endogenous endophthalmitis and they do not show signs of systemic disease very obviously. So be mindful that it's not always the guy who might be very unwell with all the features that were described. I have had patients sitting in front of me with a liver abscess and endogenous endophthalmitis and unaware that they had a liver abscess. So it's just a reminder that not always people who may be very bad can have that. It can happen in people who look apparently okay.
And Janet?
Yeah, so finally, I totally agree with you, Carlos. Absolutely. And with also of the extremely excellent lecture that you gave at the beginning of this conference. It was really, really good. So I just want to point out that these are the easiest type of cases that someone can see. Even if an eye is infected, you will eventually figure it out, and maybe not be happy when you do figure it out, but it will present at some point. Birdshot has very clear diagnostic features. It's becoming much easier to diagnose, but there's a huge category, as Mark referred to, that doesn't have a diagnosis. It's posterior uveitis, and it's a lot of uncertainty with that. Just let me remind you that the unforgotten tissue in posterior uveitis is the choroid, okay? And you have to know what is going on there. And there are lots of clues, even for infectious retinitis, in terms of what's going on in the choroid. So I'm an advocate for imaging of that very important tissue. So that's it.
Well, thank you, friends. It's indeed very humbling to have nearly 250 of you joining us from different parts of the world on a weekend. And thank you so much. We have noted the fact that you want more about the doses and SOPs. And actually, IUSG has already taken this into account. And Mark has proposed that we will design webinars on the methodology parts, how to give injections, the dosing and everything. So that's already in the pipeline. And our committee being led by John, with Alejandra, Rima, and everyone else, is working extremely hard on these webinars. And I would like to thank you all the speakers, all the presenters, fellows. You are our future IUST members, so don't leave us. Try to be in it at some point. So with this, I would like to thank you all. You will receive your feedbacks. Please send it back to us and the CME credit hours. I would
Let
give it
me,
to John to announce the next one. Over to you, John.
yes. So I'm sorry that somehow the flyer escaped being made by now, but it's all settled. So our next meeting will be April 13th. So we're, continuously on the second Saturday of the month. We'll be talking about pan-uveitis. Our own Rima Bansal will be the thematic lecturer, and we have cases with Lucia Sobran, Sapna Gangaputra, and Ariel Schlein. And so that should be an excellent session. And then we'll continue to sort of focus more on particular topics over time. We'll have July and August off, but we'll probably be running well into 2025, going through the various topics in our case-based format. So I'd like to say again, thank you to all of you who generously volunteered your time as speakers and fellows and sort of officers providing input into the discussion. And this was really a great session. Thank you so much. And we'll see you next month.
Thank you, John. Thank you, Vishali.
Thank you, everybody.
Thank you.
Thank you, everybody.
Yes.
Bye.
Thank you.